Welcome to Behind the Sports Medicine Podcast, the podcast that pulls back the curtain on the evolving world of sports science. I'm Andrew Rizza, an athlete trainer with decades of experience in professional, collegiate, and high school sports.
And I'm Cameron Roth, an orthopedic surgeon and a consultant for the Chicago White Sox.
In each episode, we'll explore the real-world challenges and opportunities facing today's human performance professionals.
Our hands-on experience is transforming sports medicine and breaking barriers through innovation and teamwork.
Today's guest is Sam Hughes, Director of Clinical Education and Clinical Assistant Professor in the Athletic Training Program at the University of Idaho in Moscow, Idaho, the University of Idaho Vandals. Sam, welcome to Behind the Sports Medicine Podcast.
Hello, thank you.
Thanks for coming. So first question right off the bat. How has clinical education, in your opinion, changed since you were an undergraduate or graduate student to now that you're in charge of teaching allied health professionals?
Yeah, I think that clinical education is really, we've seen a kind of a wave happen over the last couple years. When you think back to the kind of internship route that people had, we had students that were so involved where they didn't have to, go through specific courses, and they were just going out and just getting experience. And then we went to, clinical hours and also doing coursework. And now we're at this point where we're getting the immersive model back, and we're seeing students go out to their clinical sites and getting that full picture of what an athletic trainer does. With that, they're not limited by class time. And so that's what I think has changed the most, where at UI we really work to adapt and get the most out of that experience. So kind of a traditional model, a student could be in class from 8 to 12, and then they do a normal clinical rotation where they go out to their site for in the afternoon. And so they're only seeing a small picture of that. And now this immersive model has allowed students to get away from that time barrier of being in the classroom and being there with the athletic trainers during the prep, during rehab, during the staff meetings, during strength and conditioning, and not just sitting around waiting for something to happen at practice. We're getting the treatment and the actual patient care that our students are being able to do that. And so at the University of Idaho, again, we really embrace that immersive model. So our program is built a little differently than what you may see across other master's programs. And so we have a hybrid approach. So all of our students come to Moscow, Idaho during the summer semester, and they get all of their hands-on courses during that time. And so they're getting anatomy, rehab, eval before they even step into their first clinical rotation. And then from there, we go online for fall and spring, and our students are out at their clinical sites all over the country. And because we're online, doing courses like research methods or ethics and administration, things where you don't have to necessarily learn something that you have to apply directly to a patient, they can be out at their clinical sites, still doing coursework online, but again, they're not limited by class time. We still meet via Zoom once a week, but again, they're there whenever their preceptor, their certified athletic trainer is at the clinical site, so they can see the whole realm of patient care. And that's, again, how I think clinical education has grown over the last couple of years. So we're getting more hands-on experience for our students.
Now, being an athletic trainer myself, I went through the undergrad athletic training program as a BS in athletic training. Our clinical education was widely different, night and day. I've been a clinical instructor for almost 30 years with Northeastern University had their program, and then the Cell College has theirs, the Cell University. I've noticed the paradigm shift where you're adding more gen med and more specifically outside of the traditional athletic training. Can you speak to a little bit about how the diversity of athletic training, how it moves through those different types of experiences, whether it's traditional, industrial, gen med? How do you guys shape that for your students?
Great question. So specifically for our program, we really base it off the students' goals. So Obviously we're going to meet the CAATE standards and get our students different experiences across a variety of patient populations, a variety of different settings and things like that. But if I have a student who is set on being in the collegiate setting, I'm going to get them the experiences across a variety, but then focus on being in that collegiate setting. If I have someone that wants to be in the industrial setting, then we're going to really push for them to get that clinical experience there. But now I think the CAATE is really shaped our standards to make sure that every student's getting the most out of each clinical experience, where we're tracking their patient encounters, which we're seeing exactly what patients they're seeing. We're also kind of pushing the documentation side of things, which, athletic training we're not the best at that as a profession as a whole. So that helps push that for our students. And then I think the biggest thing is just getting more autonomy for our students. I can talk a little bit about our on-campus clinic, where we give our students full autonomy with our patients. But that's the biggest thing that I think we're seeing growth in clinical education, and then we want to see continued growth, because we don't want to send students out to a clinical rotation where they're just, doing water, doing the field work. We want them to get hands-on care, and we want them to process their clinical reasoning and push that. And I think that's, again, where we're seeing that growth there.
Our live series at the NATA convention is sponsored by Met1 Technologies. Looking for innovation in orthopedics? Meet the only U.S.-based, Latin-owned manufacturer originally focused on spinal implants, now leading the way in upper and lower extremity solutions. They've just expanded their portfolio with the newly launched Fortis Distal Radius plating system, 510K cleared and designed for next-level performance. This isn't just progress, it's representation, precision, and results, all in one. Today's episode is sponsored by Get Raw, a potent antioxidant blend made with all raw organic ingredients. The Get Raw ginger turmeric formulation is 200 to 300 times more bioavailable to the human body. Documented benefits include decreased inflammation, improved digestion, immunity, cognition, and more. Get healthy, get well, get raw, the organic wellness shot.
So you mentioned CAATE, and for people that are listening who don't know what CAATE is, can you explain what CAATE is, and how does that apply to the educational platforms for universities and colleges with athletic training?
Absolutely. So the CAATE is the Commission of Accreditation of Athletic Training Programs. And so what the CAATE does is it tells us what we have to teach for our students to be able to graduate from an accredited program and then be able to pass the board certification exam.
Yeah. And is there an accreditation process that's only so many years of accreditation? And
yes.
What do you have to do in order to stay on the good side of CAATE?
Yeah, great question. So every year we have to do an annual report. So we're submitting our metrics of our student success, how many students have graduated, how many students have passed their board certification exam on the first attempt or any attempt. We see that percentage and compare that against different programs. We also have to submit a bunch of different metrics of from the academic side and from our clinical side, making sure we're hitting those standards of, are all of our clinical rotations up to standard? Are they having preceptors that are certified athletic trainers? Are they providing a quality experience for our student? So that's an annual checkbox. And then depending on the program, there is a reaccreditation process. And so how you do on that depends on how you do on that marks how many years you are accredited for. So in that process, again, we will have a committee come out and they check to make sure we're hitting all the standards. Are we teaching the specific things? Are we tracking the specific things to make sure that we can stay accredited? Our last report was in 2018 and we were given 10 years. So 2028, we're almost there and we're prepping for...
Prepping and getting ready.
Yes, getting ready for that.
One of your official titles is the Clinical Assistant Professor of Movement Sciences. What are movement sciences?
Great. So movement sciences is our department. And so that houses a couple different programs for us. It's kind of just a catch-all term that describes our programs in this department. And so we have athletic training, we have kinesiology, we have exercise science, and we have a dance program and a couple other things there. What's interesting,
In Moscow, and so dance
right.
classes over the summer.
And I believe our university has two different dance programs. We have one where it's like you're focusing on dance, and then this program where it's talking about like the biomechanics and how to analyze the body
Science
movements.
of
Yeah, right. So very interesting. But we have a medical school at the University of Idaho that is part of a conglomerate of different universities. It's called WWAMI, and it includes Washington, Wyoming, Alaska, Montana, and Idaho. And with that, we're actually expanding our health professions program. So we just started a doctorate of anatomical sciences at the University of Idaho. We have a master's in gerontology. We have hopefully we're working at the state board to get a nursing program hopefully approved. And, in the future, we would love to expand to PA if that's open, or PT, but none of those others aren't confirmed yet. But so we're moving to what we call SHAMP, School of Health and Medical Professions. And that would be under our college's graduate studies. So we fit in within movement sciences, but we'll be with more like-minded programs at some point.
Is there a medical school at the university?
Yes, WWAMI. So they are a part of that conglomerate.
So you're associated with the University of Washington Medical School?
The medical school is, yes. Our athletic training program, no. In the future, they're hoping to expand and create their own medical program. I think that's an idea for the state, because we want to get more physicians, more healthcare workers within the state of Idaho.
I also took a detailed look at your course list, and you teach a lot of courses, but there were two that really stuck out to me. Number one is scientific writing for publication in patient care, and number two is ethics and administration in athletic training. So can you give us a brief bio on those and what you find so I find those very specific, interesting, and unique, and I'd love to hear your opinion as the professor.
Yeah, so I'll start with the ethics and administration. That's in our master's program, and I'm sure every master's program is going to have that course. And athletic training, the fun part is to be able to work with patients, and the administrative side of things is probably the least fun part, right? But we need to be able to do those things and track and document and protect our patient data and things like that. So that's the main focus there, and then also ethics, protecting our patients, protecting ourselves as clinicians. So more of a less hands-on course. It's still really fun, but our students like that course because we're stepping away from the clinical reasoning side of things and diving more into the textbook for that course. The scientific writing, that is one of our doctoral courses in our DAT program, and that one is situated in our second year of our DAT. And so our DAT program, our main focus is advancing patient care and manual therapies. And so in that, we have a research component for our DAT. It is 2 publishable manuscripts. They don't have to be published, but they have to be publication ready. And so in that course, we're just fine-tuning and honing in on those 2 manuscripts that our students are working on. Typically, that research is focused around what they're doing out at their jobs and in their own patient care. So typically we see case studies or case series there. Sometimes we'll get a critically appraised topic from a student. But again, focused around patient care, what new things they're learning within the program, and then how they're applying that at their job.
How have students changed most over? What have you noticed with students coming in, and is that one of the reasons why schools are trying to provide a hybrid type of program, or is that more on the lines of professional experience as a professional?
Trends I've seen. Well, so our program, we were hybrid before COVID. So that COVID transition was easier for us. We didn't really have to change that much besides some of our clinical rotations. The academic side of things, we've been hybrid fall and spring since the start of our master's program in 2013. But trends that I have seen, good trends or bad trends?
Both. I would say both. I'd say more bad than good. We'll take on both. Yeah.
Good trends. I mean, I think just with the master's program in general, we've seen students come in with a little bit more observation experience. And so luckily they're coming in, knowing what athletic training is, because that kind of used to be a problem. They would come in thinking athletic training was like personal training, and then they get into it and they're like, they didn't do their research, and they're like, what is this? This is not what I wanted to do, or this is way too hard. But now I think with more observation experience, they're coming in knowing that this is what they have a passion for, and they know their goals once they graduate. So that's a great trend. On the other side, I think that we've really had to work to give our students the why. And that's been really helpful, because sometimes they're like, this seems like busy work. Why am I doing this? And if I tell them, okay, actually, we have to be able to assess you on this for accreditation standards. That's like the basic foundational reason. But also if we say, okay, this is going to help you in the future of treating a patient. One of the things that I think our students struggle with or don't love as much is we really focus on patient-reported outcome measures. And so a lot of our journals are having students use patient-reported outcome measures out at their clinical rotation with their patients. And that's a struggle because sometimes their preceptors aren't doing that. And then they're like, why, if my preceptor's not doing it, why do I have to do it? And then we really dive into, okay, if you're not tracking your progress on your patient, how are you making a change with your patient? That's the main reason why we're doing it, but also you can show your worth as an athletic trainer. So when you leave and you're working at a job and you're fighting for a higher salary, oh, I have all these metrics to show, okay, I'm making a change within my patient care. My patients are having less time loss after injury. My patients are getting from a 7 on the NPRS scale, the numeric pain rating scale, down to a 0 by their second visit. I want to take more CEUs in this course because I found it useful at reducing pain, increasing function, and you have all these metrics to use. And so I think students are coming in thinking things are busy work and not understanding the why behind something, and that's something that I personally as an educator have been trying to do is give them that why.
Do you think patient-reported outcomes is important for the future of athletic training on justifying position in certain secondary school or even collegiate settings? And then also, it's a higher edition of how you think that's an important piece of it's justifying our role as athletic trainers.
Absolutely. I think, again, athletic trainers aren't the best at documenting, and it seems tedious, and we're overworked all the time, so what time do we have to document? But yes, it's going to show what we're doing, how much help we need, again, how well we're doing what we're doing, and justify a raise, justify more help, justify taking a new Con Ed course or anything like that. So that's the kind of selfish side of things for athletic training. But on the other side, a patient-reported outcome measure, if we just focus on the physical and we don't think about the disablement model of all those external and intrinsic factors that are playing into the physical component, we're not seeing the other side of things, and if we're not looking at the perception of someone's pain or someone's dysfunction, we're missing a whole piece of patient care. And I think that's the easy part, is just to do the physical, because that's the textbook answer, right? Things we can go to the textbook to figure out, and the non-physical things are things that are a little bit more challenging. And yes, we can refer out, but a lot of times just understanding what they're feeling about that pain and dysfunction can be really helpful to understand risk for injury, risk for re-injury, and then progression after an injury.
Are the athletic trainers at the university synthesizing and then analyzing that data? Obviously, they're collecting. And one of our previous episodes with Rob Otash, he has an electronic medical system for athletic trainers that collects patient-reported outcome measures. And he says he uses that as a tool, and then the information gets passed to other people to synthesize and analyze the information. So not only are you at the university collecting the information, but who is synthesizing it and analyzing and publishing?
Yeah, great question. Right now, I think within our ISMaRT Clinic, where our faculty and staff are working and our students are treating patients, we're seeing them review those patient-reported outcome measures in a sense of, for each patient case. On a larger scale, analyzing that, we have so much data. We have a study running right now that is looking at the DPAS, the disablement and the physically active scale, and creating hopefully a better version of a scale to be used to assess physical and non-physical well-being for patients. From a student perspective, hopefully in the future, maybe, we'll get some research out there about our ISMaRT Clinic where we are analyzing that data. How effective are our students at treating patients in decreasing their perceived pain and increasing their perceived function?
And you keep mentioning the ISMaRT Clinic. Can you tell us a little bit more about that and if those other models like that across the country?
Yeah, so our ISMaRT Clinic is the integrative sports medicine and rehabilitative therapy clinic on campus. We've seen a couple of those across the country. I believe Indiana State has a version of a clinic very similar. Typically, we don't see that in athletic training a lot. A lot of PT programs have clinics like this where they have PT students working with patients. But our ISMaRT Clinic is fully ran by our faculty and staff within our program. We have two co-directors that are overseeing that, and then our program director of our AT program, she is dual credentialed AT-PT, and so she oversees the clinic as well. So we have a variety of clinicians that are working in there. And then our students take full patient loads. So I really encourage our students to do a rotation within our ISMaRT Clinic because it is the most clinically challenging rotation that we have in our program. It's a sink or swim situation for our students. All of them swim, none of them sink. They might feel like they're sinking, but they're thrown in doing evals, clinical reasoning, doing the full treatments and rehab, obviously with the overseeing of our preceptors, but it is the most hands-on experience that we have for our students.
Back in my day, we still did notes on granite or chisel. That's right. So we walked uphill to and from, no shoes on the snow. So clinically, we had, you're going to this university or college for clinical rotation. You might go to a private practice. There was no gen med. We did university rotation, like at Northeastern in the University Clinic, if we got placed there. So it's standards. Like I had to do football, I had to do hockey, like high velocity, high contact, high rate of injury sport. And then we had to follow through with the rest. So it's definitely changed. Like it's night and day from what it used to be. And it's for the better because I think there's so much more variability in athletic training now and how we work as professionals. And we're in so many marketplaces that it's advantageous to have that. So I think, it sounds like you guys seem like you're the locomotive, not the caboose in the train, where you're trying to get your clinical education moving into the right direction, everybody follows.
Right, absolutely. And what's so nice about the CAATE, the accreditor of athletic training programs, is we have all these standards, but some of them, they tell you how you have to meet those standards, and some they're like, as long as you're meeting the standard, you can do it any way you want to. And so that's really my predecessors, they built this program and built this immersive model, and yes, we're hitting the standards, but we're doing it in a completely different way. And you mentioned gen med experiences. If we had every student in Moscow for all of their rotations, yes, I would have them go out to see a physician in a gen med facility for a rotation or for a week or something like that. With our model, our students are all across the country, so that's a little bit more challenging, but we definitely ensure that our students are getting the exposure to gen med cases or getting exposure to different types of healthcare practitioners beyond an athletic trainer.
Now, if a student comes to you and says, hey, I get this unbelievable opportunity
Yeah.
to go overseas, is that actually feasible? And if it isn't, how do you then make the experience memorable enough to that student that might be similar in the United States?
Absolutely. So one, with all of our sites, I make sure that a student's going to get a good clinical rotation. All of our preceptors and sites are vetted. If a student wants to go in the NFL and there is a rotation, but the site was like, hey, you would only do water, that's not a good experience. Yeah, right? Going overseas is a little bit more challenging because our standards are a preceptor has to be a certified athletic trainer or a physician. So if we could get something worked out where the preceptor is a physician and we're still meeting all the standards, absolutely. The other side of things is, per the standards, we only have to get an immersive rotation for a certain amount of weeks. I believe off the top of my head, it's a minimum of 4 weeks, and our students get 4 semesters of an immersive rotation. So I could take a student's semester off and they could go get that experience, and it just wouldn't count as an immersive experience, but they still have 3 other 16-week rotations that we're leaning on there.
How much crossover do your trainees have with orthopedic surgeons? So do they get to train or work with them during their educational period?
It depends. So it depends on the site. I would say not a lot get a lot of experience with an ortho surgeon. I have a couple students and a couple sites that are hospital-based, and so in those cases, yes, they are working with an ortho surgeon. At a high-level collegiate rotation, if we have a patient that needs surgery or something like that, then yes, they're getting that exposure. But someone at a high school, maybe not. But again, we're getting a variety of things, so they're at least getting that exposure at least once within their time in the program.
What are some of your challenges today with athletic training education as a program, and maybe more specifically clinical education related, if any?
Yeah, challenges within programs and clinical education. I think I'll start with clinical education, and then I have something on just AT education as a whole. In clinical education, I think another trend that I've seen in students is people are a lot more vocal. I think when I was a student, or just colleagues when they were students, you would go to your rotation, you would show up and you do the work, just like it was a job.
Until it was done.
Yeah, until it was done. And then now, I don't know if it's social media or just people trying to be more authentic, and if they don't want to go, sometimes they're like, I'm not going to go.
Well, that's their authentic self. They don't want to show up to work.
Right.
Them being authentic.
Yeah, right. I wish I might have to do that a couple days.
You get better and you're strong. Authentically, I don't think many people want to get it.
Yeah, right.
The rest to get stronger, right? It's true.
The other side of it is just the personal interaction with people. So when I first started, it was matching people with their goals and their clinical sites. And now I'm really starting to work to match personalities. And I didn't think that was going to be in my job description at all. But it is a big piece of it. I got to make sure that a preceptor is going to work well with a student. And if they're not, then I'm not going to send them to that rotation. And it's just another layer onto that I think that has been a challenge that I've grown in and continuing to grow in over the last couple years.
It's interesting because I don't know if it's generational or not, and you and I have talked about this, Cam, but I think as an orthopedic surgeon, when you move out to residency, fellowship, and training as a physician, you had to do what was needed to get better and to get to where you needed to be as a physician. You never said at 3 o'clock, you know what, I'm going to clock out and leave.
Right.
So in athletic training, it's always been, for us, even coming through as young athletic trainers and moving up, was now being more seasoned than adult, is that we're there until things are completed, because that's what our job description is. It doesn't necessarily mean it is right to do 80 hours a week, but if we're the only coverage that's there, or I should say medical professional on site to provide the care that is needed, then we have to figure out a way to have, if we're working for a school system, how to orchestrate everybody together instead of being so far apart with scheduling and things like that. So how do you educate them on providing that type of care and it to be meaningful enough for them to understand that, hey, there may be some weeks you're working a little more and weeks you're working a little less, but you're providing the care you should be to care for the people you need.
Right. I think part of that is an untaught skill. And I think that a lot of people coming into athletic training and knowing what it is. And I'm hopeful that before someone applies to an athletic training program, they look into the profession, they look into the mean salary, and they understand, okay, maybe this isn't the highest paying job. And then they come in with a passion of helping people. So I think that is in most people when they enter an athletic training program or enter the profession. And so that's where we start to see people that are working, over 40 hours a week, and they're staying to that end goal of getting things done. And it's because of that passion, because they may be the only healthcare provider that's going to be able to provide that coverage, and they're not going to walk out on a patient or something like that. So having that passion to help others, I think, is the untaught skill. The other side of it is, walking them through what an actual day in the life of an athletic trainer is. And I think that's where those immersive rotations come into play. They're seeing that before they actually are certified of, okay, the schedule can vary. A high school schedule is very different than an industrial setting. A collegiate schedule, sport to sport, can differ, right? And I think that's where they start to see my schedule may not be the same every single day, every single week. We have a lot of students that come in that, higher education is expensive, and they do have to have jobs sometimes to fund their degree. And I think that's a challenge that we've run into where, yes, I want to help you, be able to work, to be able to afford to come to this program, but at the same time, we have to prioritize your clinical schedule. And again, we have to make sure that matches your goals, and that schedule can change. You could 1 week be having your clinical rotation in the mornings from 5 a.m. to 12, and then the next week you have games where you're there until 11 p.m. And I can't predict that as a clinical educator or clinical coordinator, and most of the time your preceptors aren't going to predict a lot of changes, months in advance.
There's been a common thread among all of our interviews today, and this is a little outside of my wheelhouse because I'm not an athletic trainer, but it's that athletic trainers need help because, you're working so hard, and I think you and Riz are 100% right. You guys are staying until the work is done, and clearly you're ingraining that into your students. But for my education, where is that help coming from? Is that more athletic? Do we have a shortage of athletic trainers? Do we need more interested high school and college interns to help you? Is it more shift work? Is it more allied healthcare professionals to help you? Where can your workload be offloaded to help, create the best personal and professional success for athletic trainers?
Yeah, I think one, there is a shortage of athletic training or working athletic trainers. I think one comes from, when we shifted to a professional master's degree, a lot of programs went from having 20 to 30 people in their program to now the mean is around 10 to 12. The other side of it is the salary that for an athletic trainer. And, I applaud people that are standing up for what they're worth and then not taking a job that's not paying well. And then we see these holes within different schools. And then you have 2 athletic trainers covering 19 sports at a college. And, that's where we're seeing that shortage. So one would be a higher salary. I think that would get everybody, back to their previous jobs if they left the profession, and then increase the numbers within programs. What I think I have seen grown is sports medicine programs within high schools, and that's funneling straight into the master's programs. A lot of the ones that I see are in California. We have a bunch of different high schools that have amazing sports medicine programs. Then we also have a couple of community colleges that have some programs that, again, are funneling in. So they are getting some help there on that end, but it's still not filling that void of having certified athletic trainers.
And you talk about a little bit about, I'll put it in quotes, but alternative education paths. And I'm just saying not attending a 4-year university and going straight into the profession that you want to do. Do you think that athletic training could benefit from, students who go directly from high school and maybe do a 2-year associate's degree and then get some sort of master's or advanced degree or certification in athletic training and add to the workforces and be just as effective? Or do you think You still need to have the 4 years of college over your belt, still need the master's program, still look for the doctorate, because as a physician, we have certain types of physician, family medicine doctors especially. You have a shortage of those across the United States. And now they're actually shortening med school or providing full loans or paying for all your books for the med school if you promise to become a family medicine. Do you think there's alternative paths for athletic trainers to help boost the workforce?
Absolutely. I've seen similar programs. One I saw was out of Fargo, North Dakota, and then there's another one with Ochsner Health out of New Orleans. And they have a very similar system where they're saying, hey, you guarantee us 2 years of work and we will help fund your master's degree. And I think that will absolutely help people get into the workforce. And I think some of our lower numbers and cohorts within the professional master's degree started off because it's more schooling, more money, all of those things. But we have been seeing different pathways pop up. So at UI, we have a couple different pathways. We have a 3+2 pathway where we have students come in, get their 3 years of undergrad at the University of Idaho. Their fourth year kind of transitions into that first year of the master's program. So they're getting it within 5 years. I feel like that's pretty common across a lot of master's programs for athletic training. Another pathway we call a 2-1-2. And we have a couple different institutions that we are connected with, mainly in California, where we have students do 2 years at a community college. They come to UI and do 1 more year of their undergrad, and then they transition into their 2 years into the master's. And so again, it's 5 years total, but not all the first 3 are at UI. And so I think creating those flexible pathways is going to be really beneficial with getting more students into programs.
What advice do you give athletic trainers that may want to move into a clinical role as a clinical educator?
My first advice would be a preceptor. That's the easiest way to get your foot in the door with an athletic training program, easiest way to get your foot in the door with teaching. I didn't have any background in higher education, I guess, before I was in higher education, which makes sense. I subbed at a high school for a couple years in Florida. I worked for a cheerleading organization over the summers, so kind of teaching-esque vibes there. And then I took a role as a teaching assistant when I was in my doctoral program. I didn't want to start the lowest on the totem pole, but sometimes you have to. But again, a preceptor role is a great way to get started there because you have to teach. We lean on our preceptors so much during the year because they're the ones teaching or checking off skills that our students have already learned, and sometimes reteaching skills because I don't expect all of our students to get everything the first time in the classroom. But yeah, that would be my main advice there.
How do you measure success in the clinical education environment for both student and preceptor? When is it, like if you're having some great successful outcomes versus not successful, how do you then make the shift? So either should I keep people in that unsuccessful, the preceptor-like environment, or do you quickly pull people? How do you work with them to make sure that you have enough positions for those students? Great question. And it does become challenging, especially if I have students across the country. Like if I have a student in, let's say, Pennsylvania, and I'm only saying that because I don't have a site in Pennsylvania right now. But if I only had one site and a student was there and I had to pull them from that site, I would have to scramble to find and create an affiliation agreement for a random place really fast. So it's not our goal to pull students from sites unless there is a reason, whether the student is not performing up to expectations or the site or the preceptor is not performing up to expectations. But really, I think what it comes down to is communication. We see a lack of student communication between the preceptor and vice versa. So if I have a meeting with a student, I'm like, okay, did you talk about this with your preceptor or with the preceptor? Did you tell the student they aren't meeting these expectations? And they're like, well, no, I didn't. I'm like, okay, that's the first step. So making sure we have a clear communication pathway between the two is the easiest way. From there, we do a lot of checks and balances before to make sure that it is a good rotation. And then we have midpoint and end of semester evaluations for the students that the preceptor will fill out, and then for the preceptor that the student will fill out. And so
All of our student information about a site is anonymous because I don't want that to jeopardize any future reference checks or anything like that. But I give the feedback to the preceptors, making sure they understand this is what went well, or, this is what we could improve upon. Do you think that that is doable? If not, then maybe we don't use you in the future as a site. But making sure that we're getting as much feedback so I can understand what type of student would be best for a rotation versus what site we probably wouldn't use again.
Now, are you doing like unannounced clinical drop-ins to see what's happening? Are they scheduled? And then also, the other side of that is, are you using platforms such as A-Track to use for reporting on goals, SMART goals, clinical efficiencies?
Yeah, so we use eValue. It's a great system. We actually used to house all of our courses on eValue, but we just use it for clinical education now. And we have evaluations that the preceptor will fill out, and it's a full evaluation where they're rating them on a Likert scale on a bunch of different things. We have different components with comments, yes, no. So we're seeing a variety of answers from our preceptors on that end. We also use competency checks. So our students have skills that they must get done out at their clinical site and then approved by their preceptor. And then we have our patient encounters, and each student has to meet a certain number of patient encounters and a certain type of patient encounter. And those are all evaluated by the preceptor, making sure that the student is proficient in managing that case. I think I forgot the first part of your question, but I did have an answer to it.
So it was, do you do unannounced drop-ins?
Oh, I wish we did, because that would be amazing. I would travel the U.S. all the time because we have sites all over the country.
So sprawling for you, it's very
Right. We do monthly check-ins. Okay. So those are going to be via Zoom or phone call, or if they're somewhere near us, we'll go drop in. But monthly, at least monthly, with both the preceptor and the student.
Yeah, that's great. That's fantastic.
What is next for you in the University of Idaho athletic training department?
Next for our program, both of our programs, I think our big transition to SHAMP, the School of Health and Medical Professions, is going to be a big change. What those changes are, I don't know yet, because it's fairly new. Again, we'll transition on July 1, but I think the biggest thing there is just that interprofessional collaboration. When we're teaching suturing to our athletic training students, they're taking that with the medical students. When we're teaching joint reductions, they'll take that with the medical students and maybe PA students in the future if we have that type of program. When they do IV, they'll do that along nursing students if we get that program up and rolling and approved by the state board. So just that, interprofessional collaboration, I think, is going to be really big and something we want to see across all healthcare professions, because athletic training, our scope is so broad and we do so much. And sometimes I think we don't like to lean on other healthcare professions, but we want to make sure we create a well-rounded sports medicine team, and getting students that exposure early on in the classroom is going to only set them up for success later on.
I want to point out to anybody that's listening that does not think that athletic trainers should suture.
The second time we've heard that.
Provide reduction in a dislocated joint. Yes, it is being taught at the athletic training level, a CAATE curriculum. So anybody listening from the Board of Valley Health in Massachusetts, sorry, and Jamie, if you're listening. I have two final questions that I think are appropriate for us here, is that if you could change one thing about athletic training education, what would that be?
I would, and I feel like this is going to be so broad, it's not going to be very specific. I think that obviously in the professional programs, we have to teach the foundational information to our students to be able to pass the board certification exam and provide adequate patient care. What I would love to see is programs push past that boundary. Our goal at UI is, our mission is not to get students to pass the board exam. Our goal is to make really good clinicians. And so yes, we teach all of the foundational information. They have all of their textbooks, but we want to create good clinicians that are taking care of their patients. And so we're going beyond our Prentice or Starkey textbooks. We're teaching them different techniques that they're not going to get anywhere else until they're certified and they take a Con Ed course, things that are going to help their patients get better, and then teaching them how to track that patient care. And that's what I would love to see across all programs. Just, again, stepping past that foundational information and really diving into that clinical reasoning, really diving into the holistic approach of patient care, not just looking at the physical components of things.
If you could summarize in one sentence your mission as an educator, one sentence.
One sentence.
Distill your entire training and expertise down into one sentence.
Wow.
It could be a long sentence.
It could be a very long sentence.
A really long run-on sentence. I think my goal is to meet students where they are, to help them push towards their goals. And that's like very short and sweet and doesn't cover anything.
Less is more.
Right, less is more. But yeah, I mean, I could expand on that, but I don't have to.
That's perfect. And I love the Starfy reference. So Dr. Starfy was my clinic director at Northeastern back then.
It all comes full circle.
Yeah,
Sam,
great
we really
textbook.
appreciate your time, your expertise. Congratulations on your growing profile in the academic community, and we can't wait to see where you and the University of Idaho, lead us into the future. So we really appreciate your time.
Awesome. Thank you, guys.
Thanks a bunch.
Yeah.
Awesome.
Perfect.
Sweet.
Thanks for listening to Behind the Sports Medicine Podcast. Follow us on social media and check out our website.
The information shared on this podcast is for educational and informational purposes only and is not intended as medical advice. Please consult a licensed healthcare provider for guidance related to your specific situation. We'll see you next week.